Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data. Proudly brought to you by Pulse+IT News. I'm your host, Louise Shaper.
And I'm Dr. George Margellis, your co-host.
George, it's always a pleasure joining you in the studio. You've had a couple of tough weeks, haven't you?
It has been. Life has that a way of being good and bad. As many people may have known from my LinkedIn feed, I lost a very good friend of mine at the age of 53 a couple of weeks ago, a sudden heart attack on the soccer field. That was sort of an eye-opener. This guy was one of those guys who was very actively involved in the community, but also someone I was hoping to get onto our program because he was actually one of the chief digital officers over at Commonwealth Bank many years ago and had a big role there. So that was a bit of a shock. To Emmanuel Alfieras, I pay my respects to him. He was a great guy. Just recently, actually, whilst we were at HIC, my brother-in-law, Jack Passaris, who was another doyen of community. He was one of the original multicultural leads in Australia who introduced it back in the early 60s and had a 50-year career in both politics but also in community services, passed away. So I pay my respects to him. But it also gives us an opportunity to realise that at the end of the day, fragility of humanity and how we would deal with it. The bizarre thing, of course, was that at HIC, I was on a panel looking at technology and dying. So it was an interesting discussion there. We did discuss the technology side, but then we discussed about that broader philosophical and policy issues around death and dying in Australia. And I think it's an important issue for us to keep our minds about that. Whilst healthcare does a great job in keeping us alive and hopefully keeping us healthy, the endpoint is the endpoint, and we need to put that into our equations as we go forward as well.
Yeah, absolutely. Well, thanks for sharing, George, and I'm really sorry for your loss. I hope you and your family and your circle of friends are doing okay.
But it hasn't been all bad. I mean, I have to say, I think I commented on our last podcast. I also got to see my friendly local gastroenterologist during the week as well. And yeah, like I said, it's always good to speak to someone who's had views of your body that no one else has ever seen. And I'll call him out. It's Professor George Marinos. As soon as I walked into his room, after I'd made my appointment to see him online, so I made an online appointment, picked a time that was suitable for me. So specialists aren't all Luddites. Some of them are actually quite advanced. Walked into his consultation room and the first thing he said to me was, "I love your podcast." Well, what? And he goes, "Yes, I mean, I listen to it all whenever I get a chance. I was listening to it on a plane just recently." And I turned around to the guy next to me and sort of said, "Hey, I know this guy on this podcast."
Oh, yay.
And he knows me better than most. So I think we are getting at this. And then at the end of that consultation, I was emailed the instructions for my upcoming gastroscopy and the online admission form for the private hospital that I'm having it done at. So not all specialists are Luddites, and we are moving forward in a good way. So yay for health technology in Australia.
Yes, and yay for your gastroenterologist. And good on you, George, for doing your preventive health stuff. Very good. And yeah, how cool that he was talking about and just, bragging about knowing you on the plane. I love that.
It was fun. And about you, Louise, I mean, I'm pretty sure you've always had a very busy time. We both recovered from HIC, I think. HIC was a fun event. But what have you been up to the last couple of weeks?
Yeah, I think I've just been working too much, but I did do one thing that was super cool. So I went to the Launch Vic gala dinner here in Melbourne. So Launch Vic, for our international listeners or even indeed Australian listeners who haven't heard about Launch Vic's effectively a government organisation, but all they do is to support and grow the Victorian startup ecosystem. So obviously not just digital health and health tech and biotech, but all startups. And so they have a gala dinner once a year, and I got to go along. Because as I think I've mentioned before on the pod, I am doing some work with Medical Angels, that fantastic angel investment organisation set up by two doctors, Dr. B. Mian and Dr. Amandeep Hansra. Well, I can't take any credit because it was before I did any work with them, but they applied for a grant and we won. So the gala dinner, the announcement was made that we've received some funding from Launch Vic to help us actually set up a digital health fund. So that was really cool to be at the dinner. But now we're just getting started. Basically, if anyone's got any spare cash lying around and you want to invest in digital health venture fund, give me a call. We've got a lot of work ahead of us to raise the fund, but it's really exciting. And I look forward to what we can actually do to harness those funds to invest in some great digital health companies.
That is a national initiative, but I guess we'll see a brain drain down to Victoria now as everyone heads down south to take advantage of cool stuff happening down there. So looking forward to that.
Yeah, it's cool. I'm looking forward to it too. Okay, well, we should get to our first hot topic, George. I had trouble voting topics off the island when I was compiling my notes, so we've got lots to cover. And first, we're going to head back to Ozempic, our favourite topic from our first episode. So in the last episode, we talked about 23andMe and their financial troubles. Well, George, I'm glad to say they've fixed the problem. Yes. In its recent quarterly earnings report, the US-based consumer genetic testing company revealed that it is launching a telehealth weight loss membership service, giving members access to GLP-1 drugs. So, George, I'm thinking maybe this is an avenue we should consider too. Everyone else seems to be joining the Ozempic gold rush. Is your medical registration up to date? Can we make this happen?
We can, but I have to admit it's probably not my favorite way of going forward. So look, first of all, I mean, one of the most favored terms in startup world is pivot. So it's great to see that a big company like 23andMe can still pivot. And this new business model focusing on a very specific condition, in particular those that are profitable and neglecting the rest of the issues an individual may face, is a bit of a slap in the face to integrated care and person-centered care. So I have my concerns. Obesity is a very important issue and GLP-1 drugs are a big breakthrough. But we need to be cautious and not necessarily allow the profit motive to be the prime driver for everything we do.
Yeah, I know. That's why I struggle with this myself because the GLP-1 drugs at this stage anyway are showing to be really effective and not just for what they were designed to do and also as a weight loss, but there's been so much research coming out and I see Eric Topol has been covering this as well in the States that I thought secondary improvements like indirect, so, lower heart disease or improved diseases that are inflammatory in nature because you're losing weight and you're effectively healthier. But now it looks like there are direct effects of these GLP-1 drugs. So I haven't made up my mind and look, I'm open to new ideas. But while this is great, we're providing a niche service to people who need it and there's certainly health benefits to result from that. They're only in the game because it's a profit motive. And it's not the sort of healthcare we really need and deserve. I think we can do better than just providing a single niche service because it makes money.
But we shouldn't just blame the opportunistic medical entrepreneurs. I mean, business is business.
No, that's true. Yeah, of course.
The medical community needs to take a look at its current models of care and start innovating. I mean, ideally, in this situation, your GP would be able to offer the same service, possibly in conjunction with a bunch of other GPs or other clinicians, to support your weight loss journey with GLP-1, whilst also continuing to manage you holistically. You will want them to have access to your medical records, which is something I don't think many medical entrepreneurial organizations focus on. And you want someone keeping tabs, looking out for those side effects. I think it's really important that the medical community, in conjunction with the regulators and payers, and most importantly, in conjunction with the consumers who need this to be much more innovative. They need to take the lead in innovation, not just sit by the side and complain when someone pops up like this and takes part of their bread and butter away from them. Medical Angels is a great way of exempling that. Clinician-led innovation that fits into a more holistic model of care. Because if we end up having, I go one service for my GLP-1 and one service for my antihypertensive and one service for my antidepressants. I mean, we've been developing more silos and really for the last couple of years, we've been talking about breaking down silos.
Absolutely. And certainly one of the things we're seeing more of, it's not universal, but is strong clinical governance in these startup organizations, which is so critical because, as a patient myself, while it might be great to have one service that provides me all the convenience, you know what's better is having my records follow me around and they're available to my entire clinical care team. So, the last thing we want to do is create more silos.
Absolutely.
All right, well, this sort of leads into our next story, George. Now, the British Medical Journal have just published an opinion article. The title is Patients Need Access to Their Medical Records Now. The authors, healthcare executives and patients called out the professional resistance and policy inertia that has traditionally stood in the way of patients having real-time access to their full electronic health records. And of course, they did call out that real-time access has been available for many years now in Denmark, Estonia, Sweden, and the United States, and the evidence base shows the benefits far outweigh the risks. In Australia, we are moving in the right direction and the Australian federal government is championing share by default, which we will be discussing at length later in this episode with our guest. George, I completely get why there is a professional resistance and policy inertia problem. But do you think the professional discourse can mature now that we have this growing evidence for the benefit of this change?
Patient access seems to be becoming a bit of a theme for us, which I think is a great thing. Louise, we first met back in 2004 in San Francisco at MedInfo. But whilst I was there, I also had the pleasure of meeting a guy called Dr. Tom Ferguson, who, and I'm quoting Wikipedia here, he studied and wrote about the empowered medical consumer beginning in 1975 and about online health resources for consumers beginning in 1987. He urged patients to educate themselves and share knowledge with one another and urged doctors to collaborate with patients rather than command them. Sounds like a good idea, eh?
Absolutely. I never got to meet him. That's so cool that you did.
He was a really cool guy. Unfortunately, he passed away in 2006. I tried to reach out to meet him again after that when he was based in Texas. Unfortunately, he suffered from multiple myeloma. And actually, I recommend people have a look. He actually ran an e-patient website, and his work has continued on, his legacy being the Society for Participatory Medicine. The other cool thing he did, and again, this is something that the old hippies in the audience remember, he was the health and medical editor for the Whole Earth Catalogue, which was like the hippies' Bible back in the 70s and 80s. So you young ones wouldn't recognize it.
Hang on, so what was in this Whole Earth catalogue?
It was, how to eat vegan, where to find hemp. It had a whole bunch of really bizarre things about it, how to tie-dye your T-shirts. It was a really cool publication for us old hippies. And, we reflect back on it and think, oh, my God, we did some dumb things back in our youth. But it was interesting. Focusing on that, I think with all these stories, there's always two sides. It's always easy to blame the professional side of the organisation, so saying they're the resistance. But there are definitely policy resistance and inertia barriers. But we also need to look at the impediments from the consumer side. The way it currently works, highly educated, technologically literate and well-resourced individuals can take advantage of a lot of these innovations. So when we look at it through a health equity lens, it doesn't quite look as rosy as what we should be. The other thing we need to do is what can consumers do with this information? Again, education and technology capacity, very important. But to quote a famous 20th century philosopher, Spider-Man, with great power comes great responsibility. So once we empower patients with this information, who takes the responsibility for the decisions? And this is where it really is important that we support them in developing their health literacy, make the data available in a usable and useful way, provide evidence-based support tools, provide a real person-centered system to support their decision-making. And I note a couple of years ago back, the Australian Disease Management Association had a keynote speaker out here from the International Shared Decision-Making Society. So again, these aren't new concepts. What we really need to do is just turn these concepts into reality by enabling that shared data and shared decision-making to be done. And at the moment, most of the barriers really relate more to reimbursement models and business models rather than clinical models. I think we really need to start breaking some of those barriers.
Talking about business models, it's such a passionate topic that you and I are both really keen on, George. I'm just thinking out loud here, but maybe we could actually at some stage do a special series of Pulse where we actually break down business models of healthcare and look at new ways of funding health and the challenges of that. So anyway, we'll see. That could be something we look at doing.
Sounds like a lot of fun. Definitely be keen to have those discussions.
Yeah, there's so many people we could get on to do a deep dive on that. But, in the meantime, I think at least the article, it was great to see it published in such a huge publication as the British Medical Journal. And there was a few comments online, mostly from people like e-patient Dave was like, are you kidding me? Like, we've been doing this forever. Why are we even having this just conversation? Just give people access to their data. But we're moving in the right direction. And I think making sure that we educate ourselves and are aware of this growing evidence base. It's not like this is something new that hasn't happened before and we have to reinvent the wheel. We can actually learn from others.
Absolutely.
Now, this is a story from Australia, but it's unfortunately a universal theme. So a journalist at the Australian newspaper, Natasha Robinson, has called out criticism the government is facing from psychiatrists and other clinical leaders for allocating significant mental health funds towards technological platforms, including apps, that claim to treat mild anxiety and depression while there is an ongoing crisis of unmet need for severe mental ill health, with people impacted by conditions such as schizophrenia schizophrenia, bipolar disorder, and severe depression. There's a lot to unpack here. There's a workforce crisis, mass private hospital bed closing, a rise in anxiety and depression, and tech platforms that, look, when subject to independent evaluation, sometimes they do fail on what they claim to do. What are your thoughts here, George? Is this a problem that can be solved?
Look, it's an interesting challenge, and mental health is something which is, we've really come more to understand over the last few decades. So when I first graduated medicine many years ago, it was a bit of a taboo subject. It was sort of pushed away to the side. I think one of the key things we need to understand here, of course, is that the evidence for technological tools to support mental health are not new. So Professor Gavin Andrews, Professor Peter Yellowlees, two very prominent Australian doctors, have been publishing and demonstrating on this for decades. So we know that the tools are available and they work. So again, like in our Ozempic story, it seems the clinical community has dropped the ball in not supporting and using these tools to their full effect, possibly because the reimbursement models are misaligned. Possibly there's a whole number of other issues. But the reality is, we know there's a huge mental health workforce challenge. If we can use online tools to manage some of those lower risk, lower challenging, less complex conditions, it frees up resources for those complex cases. And complex psychiatry is hard. I mean, I have to admit, during my term as a medical student, psychiatry was probably the most challenging term I had, because it goes beyond just prescribing drugs or measuring a couple of vital signs and responding to them. It really is a complex science that still has a lot of research to be done. Understanding the brain is still decades away. We can use these tools. So I think the government should support the adoption of these tools. But again, evidence-based with clinical support in a holistic care model, enabling it, shared decision-making, all those things we've been talking about need to be ingrained in the model rather than just, again, here's a depression app, go for it. Here's an anxiety app, go for it. We need to think about how they fit into a holistic model of care.
Yeah. And I must admit, I don't know, you like to say you're the grumpy old Dr. George, but sometimes I think maybe I fall into that as well, because it saddens me that the solution to social isolation, loneliness, and all of the really quite complicated things that didn't exist now that do for young people today, that the solution is here's more screen time. It breaks my heart, really. I'm not saying they don't have a place, but, surely as a community, we can do better than that.
Absolutely. And look, I see this as particularly in my work with aged care. Again, we look for technological solutions, neglecting the fact that we actually have community solutions, keeping in mind that technology can facilitate some of those community solutions. So it can help roster people to meet up more effectively. It can open up new channels, but we need to stop thinking about the magic silver bullet that will solve all our problems.
Yeah, that's right. And look, I did do some research on this because it made me think, well, what technological solutions are out there to help people that have significant mental illnesses such as schizophrenia? And I found a paper that was only published a few months ago, and it was a joint paper published by academics in 6 different countries, and they examined in depth digital mental health for schizophrenia and other mental health illnesses. So I thought I'm going to reach out to those authors and see if we can get one of them on the show to educate us all about the role of digital health in severe mental health issues and what could be done to assist.
That'd be great.
All right, now the next story, I think George needs a bit of an explainer for our international listeners. Are you able to explain the Australian institution that is Bunnings?
Bunnings is Australian men's favourite place. Although I have to admit, in my household, my wife is the big Bunnings fan. She's the one I can let loose at Bunnings and she'll carry her trolley around and come home with a whole bunch of cool stuff. For our overseas colleagues, it's probably the equivalent of like Lowe's in the US or Kingfisher in the UK. It's a big, big shed full of everything a do-it-yourself person would want, ranging from screws and nails and pool chemicals and hammers and whatever, all the way through to you can actually buy an entire kitchen and bathroom, stick it in the back of your car and take it home and install it from Bunnings. And Saturday mornings and Sunday mornings at Bunnings is the famous Bunnings sausage sizzle. So what they do is every week, a different organisation sets up a barbecue type tent outside the front of Bunnings and sells sausages, and that money goes towards those organisations to support them. So be they sporting organisations, charitable organisations, community organisations. So, yep, the Bunnings sausage in a slice of bread is a go-to for many of us here in Sydney.
Well, I think it's a go-to everywhere in Australia. Thank you for that explainer, George. Very helpful. So for Pulse listeners who frequent Bunnings in New South Wales, you might be lucky enough to live close to one of the 30 stores that are part of a research trial designed to tackle high blood pressure. Yes, come September, 30 stores will be offering blood pressure checks. Now, you won't see a nurse or a clinician at Bunnings, but a machine, a station that's like a self-serve model, which will test your blood pressure. It's a big problem. Close to 7 million Australians have high blood pressure. Apparently half aren't even aware that they do. In the Medical Journal of Australia, we just had published by the National Hypertension Task Force a roadmap that calls out the need for annual checkups, simplified treatment guidelines, and a national database to help tackle the 25,000 deaths that happen each year related to high blood pressure. And because we like to talk about business models of healthcare on Pulse and economic arguments in addition to health outcomes, the roadmap also calls out that a 25% reduction in high blood pressure prevalence and more effective treatments could result in savings of more than $91 billion, considering the current productivity losses due to hypertension. Now, why Bunnings may be as Australian as Vegemite, not something that I would say that this podcast host can personally endorse, but this story does tap into the retailisation of healthcare that we're seeing in many countries, particularly in the US. It's a topic we will invite Matthew Holt onto the show to talk with us about in a future episode. George, a blood pressure test while you munch down on a sausage sizzle, is this a good idea?
So I actually went and did a little bit of research, and back in 2011, there was an article in the London Journal of Primary Care looking at opportunistic health checks in a retail environment. And what it demonstrated that there was actually some significant cost savings for the NHS by doing this, and also some opportunities to find people. So they actually found 16.8% of the population that didn't know they had high blood pressure. Now, whether high blood pressure at a retail store is diagnostic is another issue, and it requires us to follow up on that. So I think having it available for people, again, with the right education about it. So it's not just a matter of sort of saying, stick your arm in the hole, your blood pressure is 150 on 95, you have high blood pressure, pat on the shoulder, buy a sausage, away you go. Probably because if your blood pressure is 150 on 90, a salt-filled sausage is not the ideal thing for you to walk away with.
No, it's true.
But again, in the context of having an education campaign around what hypertension means. And hypertension has been called the silent killer for decades. There have been a lot of people, incidents of strokes, incidents of heart disease, incidents of renal failure are all tightly related to blood pressure. And the blood pressure measurements have changed over the years. And what used to be considered good blood pressure 30 years ago is now considered to be high blood pressure because we've seen the evidence of the effect. So I think it's a good start. I note the George Institute is the one behind this. So they're a well-known, highly respected organisation. So again, this is about developing evidence around this because not all screening is good screening. Because again, the issue around just giving people data without providing context or without providing models of care around it are critical. But I think blood pressure is well-known, as is blood sugar, as is blood cholesterol, as are a couple of other key markers. The main concern here is that Bunnings will start serving vegan sausage sizzles, and that's really not what I look forward to on a Saturday morning.
God forbid. There'll be me and my vegan mates lining up there. We'll get the sausages those days.
So when the vegans are lined up with their active wear and I turn up in my baggy shorts and my beer belly, that may induce me to be more health conscious. So it may have a positive effect.
Maybe if I could get a kombucha with my vegan sausage instead of a Coke.
Yes, that would be an interesting paradigm, wouldn't it?
Yes, we will see. And it is something, I think you're right, George, we should revisit this again in future episodes, because one of the things that listeners might not know is that the machines that you will now see in these 30 Bunnings stores are owned by Wesfarmers Health. group that actually has acquired an enormous amount of technology companies and technology services such as these machines. So I'm wondering as well, when we talk about the retailization of healthcare, what the sort of competitive pressure that might result on traditional community health centres and primary care facilities if you can get these sort of checks done in retail centres like Bunnings. Is this a patient acquisition approach, not just a good thing that they're doing for the community?
I will start to worry when the GP is in aisle 32 and the pharmacy in aisle 36 at the local Bunnings. But hopefully we look at this more holistically. But the reality is, if you look at other parts of the world, the retail pharmacy is significantly changed, and Wesfarmers have got quite a big chunk of that market. Retail medicine has changed. So there are certain things that we need to work with and certain things we need to work against. And I don't necessarily believe that large organizations are evil and don't want to provide good healthcare, but they need to meet the same guidelines that we've always seen. That quintuple aim of the Institute of Health Improvement remains the mantra which we have to focus on.
Absolutely. All right. Well, George, I think it's time for a brief break. And when we come back, we will be back with our special guest of Pulse, Daniel McCabe, who is he's the head honcho at the Australian government for all things digital. Joining us in the Pulse+ studio is a special guest who's at the heart of Australia's healthcare system, or you might want to say close to the top, depending on your perspective. Daniel McCabe is the first Assistant Secretary for the Medicare Benefits and Digital Health Division at the Australian Government Department of Health and Aged Care. Now, for our international listeners, Medicare is Australia's universal healthcare system, with the Australian government subsidising the costs of a wide range of health services. It's massive. We're talking 460 million services to the tune of approximately $29.6 billion per year. And true story, by the time you've finished listening to this podcast episode, on average, 52,000 healthcare services would have been funded by Medicare. Well, with Medicare plus digital health, Daniel is responsible for a massive portfolio, ensuring access to medical services for Australians and playing a pivotal role in shaping digital health policy, aiming to connect patients and healthcare providers with their health information across the health system. Daniel, welcome to Pulse.
Well, thank you, Louise. Thank you, George. Great to be here.
Great to have you on board, Daniel.
Now, Daniel, you're a super busy guy, which I think in the intro we sort of covered that. But for as long as I've known you, you've always been a really passionate believer and a supporter of the importance of the work of the digital health community. So I'm curious, what sparked your passion for this space and what drives you to focus on such a complex and fast evolving part of our healthcare system?
Well, thanks, Louise. Look, I think maybe for background for everyone, I was an IT professional for 20 years of my career, and I've always been very passionate about technology and digital and how that can help organisations improve their business processes, but more importantly, our customers that are connecting into business. And so I've had the privilege of working at a few organisations looking at those things and looking at how ICT and digital can really improve businesses, but often also impede businesses if it's not done well. But about 6 years ago, I decided I wanted to move out of IT and actually think more broadly about health policy. And so I had the fortune of taking on a broader policy role to look at how we could improve healthcare in Australia, but was also given responsibility for digital policy in terms of digital health. And so I've always looked at how we can look at improving healthcare, but bringing the digital lens in as well.
Fantastic. I mean, so it's interesting always, the IT guy gets given the digital task, but like you said, your passion around how you do that is critical. And it's really exciting that someone who understands the technology, but also the policies engaged in the space. So to our international guests, Medicare is the heart and soul of healthcare in Australia. It's sort of been part of our core structure now for 40 years?
That's right, 40 years this year.
And we all sort of rely on it. So obviously having that as part of your portfolio and digital health is a great balance, because you really do balance the innovation side, but also the money side. I mean, the payment for systems. But one of the really exciting initiatives, and Louise and I and most of the community are very excited about this, is this new vision for share by default, the access to clinical information that previously stored away in individual repositories being shared with individuals by default. For the benefit of our listeners, can you simply explain what the vision is for share by default?
Yeah, so share by default is simply about information that's created about me as a patient is shared with me. Today, when you have a clinical interaction, there's a lot of information created about you, but most of the time that's shared with you by exception. And so what we're trying to do is change that paradigm so that most information that's created about you as a patient is shared back with you. So if you go for a blood test, for example, that report will become available to you, but also be available into your history so that you and other healthcare providers can have a look at that when they're treating you. Sharing by default means test results are shared with you. All your medication information, care plans, health assessments are all shared with you. And in Australian context, that means shared with your My Health record.
I find it a little crazy that in 2024, shared by default isn't already here, but I'm so thrilled that we're getting there. How do you think this vision for share by default, where we all have access to the health information about us, how will that change Australians' experience with their clinicians, that relationship with clinicians? What are your thoughts on that, Daniel?
Well, I think firstly, not having to retell your story every time you go and visit a doctor, especially if you're seeing a doctor for the first time, having that information available both for yourself and for your health provider, I think will be a big change, so people can confidently know that their story is available when they need it. But also, I think it changes the dynamic between consumers and healthcare providers as well, so that you are much more empowered to ask questions about things that you're not sure about and get views rather than having your healthcare provider try to determine what you might need to know and what might be useful for you. If you want to have more agency in your healthcare, having that information available for you is going to be really critical.
It's interesting. I mean, it's been a long journey. I reflect back, I think it was 2004, I chaired a session at HIC on consumer health informatics, and we were starting to have these discussions. Personal health records were a buzz back in the early 2000s, but they were very limited because we didn't have connectivity. So there were stories of USB sticks and the cards with memory chips on them. So moving forward now, one of the biggest challenges we always had in the early days with personal health records were what they did to the relationship. It almost became a trust between providers and patients. And there was always that concern that if the patient had their information, would that change that relationship? How do you see this share by default model changing that relationship between healthcare providers and patients?
Well, I think, George, there's probably a few dimensions to this. Firstly, as I said, I think giving consumers more agency in their healthcare is going to be critical so that patients can actually ask questions when they're not sure about something or challenge opinions. Is going to be critical in that. But actually, I think it's also about how we think about the continuum of care as well. Part of the work we're trying to do in reforming Australia's healthcare system is think about how we do more multidisciplinary care. And so the traditional relationships of a patient and one doctor are a thing of the past. Yes, it's still going to be a core tenet, but we need to think about how we support a broader care team. And so having a consistent set of information for that broader care team is going to be critical. And it's not always going to sit under one roof as well. Often, if you need allied health services, as a patient, you have to retell your story to those providers so they can then work through their best treatment plan for you. And so really what we're trying to do here is make sure that that key information about you, you're able to then share with everyone that you need to in terms of your healthcare journey.
It's so incredible. I look forward to seeing what that looks like. Have you thought through how that might look like for a consumer in terms of navigating between, let's say you've got your general practice, your hospital and an aged care facility?
Yes, and I think often those three settings are where we have information silos or vacuums, and it causes a lot of problems for consumers as they move between those settings. So you might have a regular GP, have a very good relationship, and they have your full health history, but for whatever reason you have to present at a hospital, either in an emergency setting or for a procedure, and that information is not known to the hospital. And so what we're trying to do now is make sure that previous test results, medications, so we don't end up with contraindications, are all available in the hospital setting. But I think equally and probably more powerfully is when you're coming out of a hospital, often, if you're lucky, you might get a piece of paper that talks about what was done in the hospital, what meds were administered, what tests were taken. And that's if you're lucky, and maybe the care instructions. But a lot of times that doesn't happen. And so if you go back to your GP or you're in aged care and you're living in a residential facility, they have no idea about what's happened in the hospital setting, what medications were administered. And often that means then they're going to have to second guess everything. And so what we're trying to do is make sure that we move to more seamless handovers of care between care settings so that key information is available across your continuum. And so that you don't end up back in a residential aged care facility, for example, being prescribed and administered medicines that are going to have contraindications with things that were in hospital, because then we have a vicious cycle of you've been readmitted to hospital, and we're trying to break down some of those challenges as well.
I think one of the really disruptive things here is that focus on the patient, the consumer, being at the center of this and being in control. I mean, we've often talked in healthcare, and again, having spent 40 years in medicine, about the patient taking a greater role in their own healthcare. But in the past, we've made it very hard for them. So by at least making that information available to them, and obviously extending forward for a greater communication between healthcare providers, patients, community, and everyone else, I think that's really critical. And as you point out, it really is a team sport. The good old days where the doctor did everything are well and truly gone. I'm doing quite a lot of work now in aged care, and the reality is allied health, nursing, even personal carers play a huge role in that. So being able to share information is critical. But it brings us back to that classic problem we have in Australian healthcare, fragmentation. We have Medicare, which covers general practice and private specialist cares. We have state governments, which manage hospital cares. We have various organisations that sort of separate aged care, separated from healthcare to some degree. What does it look like when we have a connected healthcare system? What will that actually look like to the consumer in the future?
Well, I think one of our opportunities/challenges is to make all of our funding silos and our different arrangements much more opaque. You shouldn't have to understand how the health and aged care and disability care systems work in order to navigate your care journey. And so for me, what we're trying to do is look at how information flows across those different care settings more seamlessly. And we're looking at that from how we fund those services and thinking about, do we make it compulsory as part of the funding to share data with that encounter as well? And then looking at how that data is shared so that it's usable across every care setting. It's all well and good for us to demand more information out of every care setting, but if it's not captured in a way that can work across different care settings, and it's going to just cause a different level of frustration for the wonderful health and care providers that work in our systems today. And we are working very closely with our state and territory governments at the moment, and there's actually huge goodwill in this space, because we know that, as you said, George, this is a team sport. We can't all do this individually. I mean, all of the interventions that we're taking at a national level are really about how we empower colleagues in state governments, our private providers, our aged care providers, to work together to share information and overcome some of the challenges that we have in terms of the way all of those services are funded. Now, it sounds easy when you talk about it like that. And I said we do have a lot of goodwill, but there's still a lot of heavy lifting to do. So for us, we are looking at legislative change and supporting government with introducing legislation that requires critical core information about a patient to be shared when they have a health encounter or a visit to a GP or a test, so that that information can flow across the system. Working with state governments to think about what are the legislative and regulatory impediments that they have in their systems that prevent that information flowing back to aged care or to your GP or your allied health worker, and thinking about, do we need to do something at a national level to overcome some of those barriers so information does flow a lot more seamlessly, but also doing that in a way that gives individuals the choice in that information flow as well. I mean, I want to make sure we do everything we can to empower consumer agency, but some people don't want to share all of their information as well. And so as we design and unblock some of these information blocking mechanisms, we also need to make sure that we respect the rights of individuals as well and give them choice in what information flows and what's known about them and who has access to it.
Absolutely. We had Liz Salmi on the show recently, Daniel, and I know you know Liz, and she was talking about a study that they published, and it was very significant numbers of people. When you get bad news through the portal, and do you want that bad news? And if you get the bad news and you read it yourself, how does that impact you? And her study showed that even when it is bad news, it was, I think, 96% people want the information. And there's also follow-on research that shows that that if you get some bad news, and you can opt out, of course, but if you do get the bad news and you're at home, well, you're with loved ones. And so by the time you go and see a clinician to actually discuss the results, you're out of shock. We can't help it. Our brains go into shock and we shut down. So there's just a growing body of evidence here behind the share by default, which has, become a movement in the United States.
Yeah, I think that's right. And I think the debate we're having in Australia at the moment is there's a lot of support from the health profession around the concept of share by default. I think everyone gets that we need to connect our health system much better than what we have today. The challenge we're working through with healthcare professionals is exactly what you've just talked about. It's when someone is getting bad news, do they need to be sitting in front of a healthcare provider to receive that news? And that's a tricky one for us. I think we're taking the view that if the news is going to be life-altering or even potentially life-ending, then yes, I think we do need to make sure that the person is supported. But we need to balance that with giving individuals more agency and choice over how their information is shared. So what we will probably do is try to strike the balance on some types of information being delayed, but most information being made available in real time with the patient. And that's something that we're working through at the moment to make sure we try to get that setting. I don't think we'll make it won't be perfect in the first instance. And I think that's something we will have to iterate, but we are trying to make sure we strike that balance so that we do no harm.
So one of the things we touched upon, of course, obviously, is the challenge here is around infrastructure. I mean, the concept of sharing information has been around for a long time, but realistically, 20, 25 years ago, when we first started these discussions, the infrastructure wasn't in place. I mean, you've been an IT professional. You remember the bad old days of client server and all those sort of things. What changes in the infrastructure have come about that enable us to do this more seamlessly, more effectively now? And what infrastructure changes do healthcare providers and consumers need to engage with? Keeping in mind that, prior to 2008, the idea of a national broadband network didn't even exist. And now it's expected that we have 100 megabit at our fingertips.
Yeah, look, that's a good question, George. I think there's a lot of things that have changed in the last 20 years that really make this much more achievable. I think firstly, the move to cloud and actually having more systems having their information in the cloud does allow for much more seamless connectivity and potentially connectivity across different settings. That comes with risks as well. And so part of that work is to make sure that as we do see more and more services move to cloud, that we do it in a way that is secure and has appropriate cybersecurity controls. But we need to move away from what still exists today with lots of servers being under people's desks in practices and in clinics to leveraging things like cloud. We also have, and I think albeit aging, the My Health record, and I think partly what we're trying to do there is think about, with our sharing by default agenda, what critical information needs to be uploaded by default so that it can be accessible not only by the person that owns the record, but their wider care team in real time. And so to that end, we need to modernise that platform and move it away from CDA and PDFs to being much more rich file-based so that we can curate information for both a consumer view and consumers can choose what they want to have a look at in their record, but also for health clinicians. We do run the risk of overwhelming clinicians and providers with way too much information. And so we've got to think about how we curate information. I'm very fortunate that I chair an oversight committee with all of my state and territory colleagues, and together we're having a look at how do we federate our complex and fragmented health system. And this is where we're generating the concept of a national health information exchange so that we can create infrastructure that allows private systems, private services, state-based services to be federated together so that we can find information when it's needed without necessarily having to copy all of that information into a central database. So that is an agenda that's still ahead of us. And then I think coupled with that, we're also thinking about what is the legislative agenda to make sure that that works. We have a very good, in the My Health Record Act, that empowers and provides authorisation for consumers to decide who can see what in their record. We're having a look at, do we need to think much broader around that act or a new act that allows information to be accessed across all care settings, both at a state level, at a private level, public-private, making sure that, firstly, that we get the authorisation and consent frameworks right, and secondly, that we allow and unlock some of the challenges that we've got with state legislation that doesn't allow two-way sharing of health information. So there's quite a lot of things we've got to do, but I think we are well positioned. As I said, we've got good legislative basis today with My Health Record. We have emerging technology such as cloud that allows much more seamless connectivity, but that needs to be done in a structured and managed way. And so I think we've got the right building blocks.
So Peter O'Halloran at the launch in Canberra a couple of weeks ago noted that a lot of these transformation projects are clinical projects, not IT projects. And I note things like My Medicare and the strengthening Medicare reports come through. So how we integrate the clinical innovation with the technology innovation is critical. I see that's something that you're sitting right in the middle of. From the provider's perspective, how does the workforce get engaged in this? Because, again, most doctors, most nurses, most allied health work aren't quite technically advanced. So what do the workforce need to do to upskill itself so it's ready for this change?
Well, I think there's a few things. I think, firstly, a lot of it is about the technology that we provide our health workforce today. It needs to be modernised as well. We are going to need to change workflows so that they're not just patient-provider or patient-clinician workflows, that they think about how they work with the greater multidisciplinary team. And that's really obviously building on existing clinical practice about how you work in a wider care team. But then also thinking about how do we teach people around not moving away from their ability to do differential diagnosis, but recognising that we're keeping up with all of the things that are going on in healthcare today is going to be challenging. And so really what we're trying to think about is how do we prepare the workforce for more clinical decision support tools, more assistance in terms of making decisions, so that you can still spend as much time as you need to with your patient without getting caught trying to understand all of the data. It's really trying to strike that balance.
Hey, Pulse Potties, Louise here. I'm jumping in to let you know that this is the end of part A of our chat with Daniel McCabe. We had such a good conversation that after the recording, we decided to split Daniel's interview into 2 parts. So if you want more Daniel McCabe, and let's be honest, of course you do, you can catch part B in the next episode of Pulse. Spoiler alert, we talk more about upcoming legislative changes for Share by Default. Believe me, it's more interesting than parliamentary question time. The Sparked program, which is the program being led by and for the healthcare community to build standards so that healthcare data can be shared and understood across the ecosystem. And of course, they're cool t-shirts. We talk about how Australia is collaborating with governments in our region and beyond, and how government is working alongside the digital health industry. So join us in the PulsePod studio for our next episode for more Daniel McCabe. Now it's time for an update from our correspondent, Kate McDonald from the Pulse+IT News Desk. Welcome, Kate. Where are you joining us from today?
I'm in chilly Hobart again today. The camellias are blooming, but there's a real struggle out there on whether to accept that spring is nearing. Winter's dragging on a bit, as it does in Hobart. So we're still recovering here from the Great HIC conference a week and a bit ago. We did a lot of pre-conference coverage and reporting from the conference floor. And now we're doing some follow-up stories on some of the great presentations, including one that we really liked from a physiotherapist called Julie Louie from Royal Melbourne Hospital on one of her studies of the patient portal that they're using for the 3 adult hospitals in the Parkville precinct of Melbourne. All of those 3 hospitals use an Epic EMR and Epic's Care Companion app for the patient portal. These are relatively new in Australia. I think we've been discussing that on Pulse for a while now. And they were pioneered in Australia by Royal Children's Hospital, where there's a lot of use of the portal by families. Other patient portals around the country include ACT Health, Macquarie University Hospital, Sydney Children's Hospital Network, and quite a few private hospitals actually are ahead of the game in offering patient portals, mainly for pre-admission information. And they're also doing things like what are called prehab and post-hab for surgery. So Royal Melbourne Hospital had some great results with its portal, which were described by the Chief Allied Health Information Officer from Royal Melbourne, Kath Feely. She won a big award at HIC for her presentation on using a patient portal for vulnerable populations. It was really interesting stuff, and she's just a terrific speaker. So if you get a chance to hear her, then go for it. It also brought to mind your excellent discussion on the last Pulse podcast with Liz Selmy. She had all of the facts and figures that I think you talked about earlier, that there's the evidence base now for sharing data with patients. We had a bit of a blog about that last week. We also decided to mix it in with a bit of a cheeky question about two of the big topics we're covering a lot at the moment, which is the sharing of notes with patients, but also AI medical scribes. So we decided to ask a question that if GPs and specialists in particular are using AI medical scribes to help them with their notes, should those notes then be easily shared with the patient? If you've seen one demonstrated, the AI can take the doctor's shorthand or acronyms or hieroglyphics, as I call them, and convert them into a clinical note for their records that can be shared with other doctors, but also a referral to a specialist or a letter back to the GP, or even a prescription, automatically generated prescription in one of the scribes that I saw demonstrated at HIC. So why not a plain English note for the patient that summarises what happened in the consultation, especially if the doctor's given them instructions on what to do, and it usually goes in one ear and out the other. So we asked the question that if doctors are using these medical scribes to help them generate these different sorts of notes, should they share them automatically with the patient? Some of our readers thought that this was a stupid question, and they told us so. But so far, 75% of readers say yes. If doctors use an AI scribe for their notes, they should share those notes with the patient. But we did get one commenter who said, clinical notes are for doctors, not for patients, and they don't have the understanding to, they can't understand the notes, which I thought was a bit of a downer, but they're the sort of reactions you get. So we also been following the travels of the International Patient Summary, which is the standards organisations have all come together to support as a way of collecting basic patient data, including diagnoses, allergies and medications that can be used if the patient gets sick overseas. Software developers are supporting this standard, but so are healthcare organisations. And this has led to some really interesting work in Canada, where some of the smaller provinces have rolled out their own patient portals and apps to allow patients to access their information. Nova Scotia has launched Your Health NS app that provides access to a lot of their patient information, including from GPs. And Newfoundland and Labrador has a My Health NL app for smartphones. But the one that's taken our eye is My Health NB, which allows people in New Brunswick to do the same. But they've taken the extra step of adding what they say is the first patient-mediated patient summary in North America. And that's using the International Patient Summary. It's a pan-Canadian adaptation of the IPS. Ontario has done its own thing, and it's something New Zealand's also working on. The summary is aimed at providing a basic set of data in case of emergency when travelling, but in the case of New Brunswick, it's also for people who don't have a family doctor who takes care of their records, so they're given access to it on their phone. IPS is also being used as a patient summary part of the My Health at EU initiative in Europe. We're covering that quite heavily in our Pulse+IT Ireland site, where they're participating in that. So we'll be keeping a close eye on this development, as the IPS could be quite useful in future.
Thanks for that, Kate. Some very interesting stories there. HIC was a great event. We saw quite a lot of discussion about how tools like Epic are being used. I note Louise, old friend Lyle Berkowitz, is working on a project in America to provide virtual care through Epic. So we should probably have a chat to Lyle in the future about how this all fits in. The idea of having tools that enable clinicians to do their job better, but also share that information. I saw the scribes. Scribes are a great initiative. I had some chats with some friends of mine who had used scribes, and they sort of said, look, they're good. They're not great yet. They're still having some challenges, and they tend to be more focused in primary care than in secondary care. So my gastroenterologist, who I referred to earlier, had tried it and found that it didn't quite work in his workflow, but innovation is what we're going forward. And our Canadian friends, good to see our Canadian friends, although I do highlight, I first learnt about the International Patient Summary at last year's MedInfo in Sydney when Louise coordinated the international event on the weekend before the conference. And we didn't even know about it in Australia. So the need for international collaboration and to have sort of to sit down in the same room, preferably in person, but sometimes virtually, I think is a really important thing for us to do going forward.
I agree. The International Patient Summary, it's so simple, but, the idea of just having a basic standardized set of basic clinical data about an individual in a standardized form that will enable you to, share that information, not just across different systems, but for cross-border care. And you can see why countries in Europe are really spearheading that. But I do note, and we didn't get a chance to discuss the detail of this with Daniel McCabe, but he'll be back for a future episode, I'm sure. But I believe that through the Sparked program, that they are actually going to be building a national patient summary, which is consistent with the International Patient Summary for all Australians, and that they've got funding to do that in the 24-25 budget. So it looks like it will be coming here.
And again, I guess part of the challenge we always face, of course, is sometimes we over-engineer our solutions. And let's start off with the basics and build on that. And the IPS is a great start for that. But yeah, we touched on Spark with Daniel, another great Australian innovation that's taking over the world. So we should be really proud of what we're doing down here and down under.
Yeah, that's right. And look, if any of the people who are filling out Kate's polls on Pulse+IT also are listening to Pulse, and I hope you are, really thank you for taking the time to not just respond to the polls, but to give your comments. I actually think it's a fantastic sign. So, you're hearing those comments, Kate, where, it's a stupid question, that sort of stuff. And while, I really appreciate the person's honesty who wrote that, but at the same time, I think it's actually a good thing because, it would be easy to assume that if you listen to Pulse, if you're reading Pulse+IT, you've drunk the digital health Kool-Aid and it's all good. It's all digital health all the way. And to see that you've got readership of people who are critiquing the systems as well, I think that's really important. And, the scribes will get better. And, there probably is an argument that for a clinical note is for a clinician. But I think when you look at what Open Notes is doing and the stuff we talked with Liz, it's a matter of modifying the note or indeed using a scribe to produce a version of a note that actually makes sense to everyday humans that don't have medical degrees, that can really help them with their care. And of course, there's no way a clinician's going to have time to write two different versions of the note. But that's a great, I would think, business case for a medical scribe to go, please generate clinician version, done, read through it. Oh yeah, it looks good. I'll just tweak this bit here. And then please generate a version for the patient and then send it off to them so that they've got a record, but they don't have to worry about all of the hieroglyphics, as you say, Kate.
Well, it was one optional question we did ask in our poll. If you agree that the doctor should share the note, how should it be shared with the patient? And some said just send it as a PDF by email, but there's the option also of putting it in as an event summary and uploading it straight to the My Health record. A lot of the reason that the My Health record isn't really used that much is that they think it takes time to, do a summary and upload it. It doesn't take a huge amount of time, but time is precious for GPs. If the scribe can do it faster, that's another business case there, definitely.
Absolutely. Any tool that makes the job more efficient is always welcome by the clinical profession.
These scribes are just fabulous. I'm loving learning all about them, and it's moving so fast. It really is what they're capable of doing.
I mentioned my brother-in-law who passed away. He was in respite care at a nursing home with this amazing GP who just did aged care facilities. And the first time we had a meeting, she pulled up her laptop and she sort of said, do you mind if I record this? I'm using Lyrebird. I said, I know Lyrebird. So we ended up having a 10-minute discussion in this room full of, nurses and whatever about how good medical scribes are. And then the chief nurse sort of went, can we get back to the topic of discussion, like the patient sitting there? Yeah, we can have that discussion as well. Yeah.
And I think the RSEGP's come out with some guidance and they're saying the risks are there and do this and do that. I think there is a risk if you don't check the notes, but you'd hope that a doctor would.
It'll improve. We don't want it to generate a 13-page verbose set of notes. You need to have say, okay, here's a summary. Then you look at the summary and going, yes, yes, yes. I mean, could you literally put tick boxes next to it and say yes, 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 no, yeah. And if it's totally wrong, then you go, okay, I'll scrap that one and try again. Exactly. 90% of the time, it'll only give you information based on what you put into it. So I think, medical scribes are a great innovation, obviously evolving. We're not necessarily perfect yet, but I think part of the innovations going forward is for co-design with clinicians around making sure that the end product is what we need. And at the end of the day, the clinicians take responsibility for what they've done. So, they have to have that capacity to review what the scribe said. So I think we made the comment earlier that we don't need a 13-page summary. We need a short, sharp, succinct summary. Probably something we need to learn in healthcare is just the facts, as the old Dragnet used to say. Gee, I'm showing my age with these old shows, aren't I?
You are, but I love it. It's good. Now I'm going to have to look up old episodes of Dragnet so I can get the cultural reference. Oh, well, great conversation. Thanks so much for covering off some really fantastic stories today, Kate. It's always great to have you in the Pulse Pod studio.
Always a pleasure to be here.
Well, that's another show, George. Man, covered a lot of ground this episode. And like Daniel McCabe, that interview, there's so much going on.
It was very exciting having Daniel McCabe with us, and also his willingness to be very open around the challenges they face and their plans they have. So the world of digital health in Australia is quite rosy. I think we're looking forward to a very interesting, exciting future in digital health here.
Absolutely. I'm very upbeat. And I wanted to give a shout out here as well to the Sparked community. Now, I'm going to put a link in the show notes, but I wanted to let our Australian listeners know that if your organisation would like to be promoted as a Sparked founding member, you just need to get involved and do it before the 30th of August. So we'll put a link in the show notes. But looking at their website, it looks like you're going to be in really good company if you haven't signed up. So we're talking pretty much all the state and territory governments, obviously federal, healthcare providers, established big software companies and startups too. So if you want to learn more about getting involved in Sparked, now's a great time to do so before the end of the month.
And their black T-shirts are really cool. So if you join up, you get one of those T-shirts as well, and that makes you part of a very cool group of health care innovators in Australia.
Absolutely.
And in aged care, there's been a strong focus on leveraging the FHIR standards as well. So I think we're on a winner here.
Absolutely. And yes, I think the T-shirts, they make it all cool, and it's a good business model there. Digital health merch, I think.
Although I have to say, the Pulse+IT podcast black T-shirts are pretty cool as well. Maybe we can start merching those.
I have had some requests. All right, George, always a pleasure to have you here in the studio with me. Thank you so much for another great episode. Can you read us out, please?
Thank you, Louise. It's always great working with you and Kate on these sessions. And I have to give the shout out that the Louise does most of the work behind the scenes. So thank you, Louise, for the amazing effort you've put into it. However, work-life balance, Louise. Let's have that discussion.
Okay.
Thank you for listening to Pulse, brought to you by Pulse+IT News. Pulse is produced by Ivan Jurek of Octopod Productions. Thanks to Nigel Chartres, Emily Mara, and Kate McDonald for contributing to today's episode. Subscribe, follow, and rate Pulse wherever you get your podcasts. You can subscribe to Pulse+IT magazine at www.pulseit.news. Send your feedback and questions to pulsepod@pulseit.news. Thanks, everyone. See you in the next episode.